So, how is the study going on? So, already adrenergic system is continuing, and whole part of the general pharmacology is already been done, and now the ANS is continuing. You have already read about the different parts of the adrenergic system, sympathetic system, adrenaline, noradrenaline, already it has been done. And now coming to the another system of the ANS, another very important system, very useful, that is the cholinergic system. So, you already know, already the recapitulation done in the adrenergic class from your anatomy physiology knowledge, that you know that there are sympathetic and parasympathetic system. Mainly this comes under the autonomic nervous system. So, autonomic means, so there is no conscious control over the functions that is controlled by the autonomic system. So, what are these functions? There may be some visceral functions, there may be some ciliary functions in the eye. So, these are under not any conscious control. These are mainly controlled by the autonomic nervous system. Now, this autonomic nervous system, we can see CNS and peripheral nervous system. This autonomic nervous system mainly comes under the peripheral nervous system. Another one is the somatic. Somatic mainly that is under the conscious control of our body, that is the somatic nervous system, and we are now dealing with the autonomic nervous system. Autonomic nervous system can be divided into sympathetic and parasympathetic. Mainly what happens, you know about the nerves. So, nerves mainly there are afferent fibers, there are central connections, and then there are efferent fibers. Okay. So, mainly these autonomic nerves, they contain a mixed nerve, they can be called a mixed nerve, that is they contain both the afferent fibers as well as the efferent fibers. The afferent fibers are more or less like that of the somatic fibers. They mainly starts from the dorsal root ganglion of the spinal nerves as well as some somatic ganglions. So, from this dorsal nerve ganglion as well as the somatic ganglion, afferent nerves start, and then there are central connections. Central connections mainly happens within the CNS, and you know within the central nervous system there are midbrain, there are medulla oblongata that mainly controls all these different types of the autonomic functions. And within these central connections, within this midbrain, there are different types of the nuclei, and these different nuclei mainly, from this nuclei the efferent fibers come out, and they mainly control different types of the autonomic functions. For example, the posterior as well as the lateral nuclei, from this mainly the sympathetic nervous system generates, and from the anterior as well as the medial nuclei mainly the parasympathetic nervous system generates. And then comes the efferent fibers, that efferent fibers are mainly motor nerves. Motor nerves, that is there are innervation to the different types of the organs, and ultimately that leads to different types of the autonomic functions, these efferent nerves. And these efferent nerves can be divided into sympathetic and parasympathetic. So, the efferent nerves of the autonomic nervous system supply all innervated structures of the body except skeletal muscle, which is served by the somatic nerves. So, innervated structure, that is where the different nerves are innervated, different organs. Only the skeletal muscle is under our conscious control. This skeletal muscle is under our conscious control. So, these are innervated by the somatic nerves, except all other visceral organs, these are innervated by different types of the autonomic nerves. The most distal synaptic junctions in the autonomic reflex are occur in ganglia. You know the ganglia? This ganglia, collections of the neurons where the distal synaptic junctions mainly occur, and they mainly happens entirely outside the cerebrospinal axis. So, cerebrospinal axis, it is outside of the cerebrospinal axis. Usually the sympathetic nervous system, in case of the sympathetic nervous system, these ganglia are more or less very far away from the CNS, that is there are the efferent fibers are quite large, while in case of the parasympathetic fibers, the ganglia are nearer to the cerebrospinal axis and the efferent fibers are usually small. Somatic nerves contain no peripheral ganglia, and the synapses are located entirely within the cerebrospinal axis. So, this is the difference between the autonomic as well as the somatic. Autonomic, the ganglia, autonomic ganglia entirely lies outside of the cerebrospinal axis from which the sympathetic and parasympathetic system grows. While in case of the somatic nerves, these ganglia are present within the cerebrospinal axis. Many autonomic nerves form extensive peripheral plexus. Such networks are absent from the somatic system. So, plexus, different nerves, intertwining of the different nerves happens in the periphery. Postganglionic autonomic nerves generally are non-myelinated, that is myelin fiber is not present in the postganglionic, that is after ganglion, those nerves, efferent nerves, autonomic nerves. Motor nerves to skeletal muscles are usually myelinated. So, skeletal muscles that is innervated by the somatic nerves, these are the myelinated nerves. When the spinal efferent nerves are interrupted, smooth muscles and glands generally retain some level of spontaneous activity, whereas the denervated skeletal muscles are paralyzed. So, when there is some interrupted, that is if there is some trauma, if there is some accident or if there is any intersection. So, ultimately these skeletal muscles are fully dependent on the somatic nerves, they will be paralyzed because there is no autonomous control on the skeletal muscles. But the other smooth muscles, different types of the glands, that is the inner viscera, they mainly comes under the autonomic control. That is why they retain some of their autonomic activity. So, these are the anatomy of the autonomic nervous system. Sympathetic, you know, sympathetic means thoracolumbar and parasympathetic means craniosacral outflow. Both divisions originate in nuclei within the central nervous system, already I have said, and give rise to preganglionic efferent fibers that exit from the brainstem or spinal cord and terminate in motor ganglia. Already we have discussed. The sympathetic preganglionic fibers leave the central nervous system through the thoracic and lumbar spinal nerves. That is why they are known as the thoracolumbar outflow. Thoracic spinal nerves and spinal and lumbar spinal nerves. From this the sympathetic nerves usually comes out. While the parasympathetic preganglionic fibers leave the central nervous system through the cranial nerves. There are 4 cranial nerves through which this parasympathetic fibers comes out. These 4 are the 3, 7, 9, 10. 3, 7, 9, 10 and the 3rd and 4th sacral spinal nerves. Okay. That is why these are known as the craniosacral. Craniosacral because there are cranial nerves. Some fibers comes out with the cranial nerves. There are 4 cranial nerves, 3, 4, you can see 3, 7, 9 and 10. 3, 7, 9, 10 through which and as well as the 3rd and 4th sacral spinal nerve. That is why sympathetic outflow is known as the thoracolumbar and parasympathetic outflow is known as the craniosacral. Most of the sympathetic preganglionic fibers terminate in ganglia located in the paravertebral chains that lie on either side of the spinal column. Already we have seen that this ganglia of the autonomic ganglia lies outside of the cerebrospinal axis. So, these are the paraganglionic chains where this nuclei usually lie, where the ganglion are present. The majority of the parasympathetic preganglionic fibers terminate on ganglion cells distributed diffusely or in networks in the walls of the innervated organs. Usually within the organs or in and around the organs there are different extensive plexus of the nerves and ganglia are present where these parasympathetic fibers are usually innervated. And apart from this sympathetic and parasympathetic system, there is another system known as the enteric nervous system that is present within our gastrointestinal tract, enteric nervous system. It is a large and highly organized collection of the neurons located in the walls of the gastrointestinal system. It is sometimes considered a 3rd division of the ANS because it is also autonomous in some way. The ANS includes the myenteric plexus and submucous plexus. Myenteric plexus is also known as the plexus of the Orbach and the submucous plexus is also known as the plexus of the Meissner. So, Meissner's plexus and Orbach's plexus, these two are the backbones of the enteric nervous system that is present within the gastrointestinal tract. The muscle layers of the gastrointestinal tract are dually innervated by excitatory and inhibitory motor neurons with cell bodies primarily in the myenteric ganglia. And acetylcholine is the primary excitatory motor neurotransmitter released from the postganglionic neurons. So, all the postganglionic neurons in most of the cases, the neurotransmitter is the acetylcholine and this acetylcholine activates different types of the receptors. We will read after this in postjunctional cells that ultimately elicits different types of the responses. So, the parasympathetic system is organized mainly for discrete and localized discharge. They mainly slows the heart rate slowing effect. They lowers the blood pressure. they stimulate the gastrointestinal movements and secretions, that is there will be more secretions in parasympathetic, aids absorption of the nutrients, protects the retina from the excessive light because they causes miosis, that is the eyeball will be small, empties the urinary bladder and rectum. This is more or less in general the activity of the parasympathetic nervous system. You already read about the sympathetic nervous system. So, sympathetic nervous system is mainly utilized in the fight and flight response, that is when we are in a hurry, when we are in an emergency, then the sympathetic nervous system takes control. But when we are in the resting stage, when the different metabolism is going on, then the parasympathetic system mainly takes over. So, neurotransmitters, already you know about the what is the neurotransmitter. So, neurotransmitter is secreted from the preganglionic fibers. They are present within the synaptic cleft and ultimately they activate the postganglionic fibers and then through the motor nerves different responses are elicited. So, the neurotransmitter of all preganglionic autonomic fibers, all postganglionic parasympathetic fibers and a few postganglionic sympathetic fibers is acetylcholine. So, acetylcholine is the main neurotransmitter in case of all preganglionic autonomic fibers. So, preganglionic autonomic fibers, in all case of the preganglionic autonomic fibers, their acetylcholine is the neurotransmitter. All postganglionic parasympathetic fibers and some postganglionic sympathetic fibers. So, for the postganglionic sympathetic fibers, the main neurotransmitter is noradrenaline, already you have read. There are some sympathetic postganglionic fibers where the neurotransmitter is acetylcholine. We will come. Some postganglionic parasympathetic nerves use nitric oxide and they are referred to as the nitrogen. They are mainly present within the endothelial cells. Within the endothelial cells, there are receptors for the acetylcholine and they are mainly activated by the release of the nitric oxide when the acetylcholine is released. That is why they are known as the nitrogen. Okay. Adrenergic fibers comprise the majority of the postganglionic sympathetic fibers. So, majority of the postganglionic sympathetic fibers neurotransmitter is noradrenaline. Majority or all of the postganglionic parasympathetic fibers, the neurotransmitter is the acetylcholine. Some very few postganglionic sympathetic fibers, the neurotransmitter is also acetylcholine. Norepinephrine or noradrenaline, substance P and glutamate may also mediate many afferent impulses. These are some very less in less of the cases. So, the sympathetic system is distributed to effectors throughout the body, whereas parasympathetic distribution is much more limited. A preganglionic sympathetic fiber may traverse a considerable distance of the sympathetic chain and pass through several ganglia before it finally synapses with a postganglionic neuron, and its terminals make contact with a large number of the postganglionic neurons. On the other hand, parasympathetic system has terminal ganglia very near or within the organs innervated, already I have said, and is generally more circumscribed in its influences. These are just anatomy about this. So, you can see autonomic nervous system, this is the sympathetic innervation of the, there are some sympathetic innervations postganglionic where the neurotransmitter is the acetylcholine. Example is the, you can see here the acetylcholine. These are the preganglionic fibers. So, preganglionic fibers, be it sympathetic, be it parasympathetic, the neurotransmitter is the acetylcholine, remember. In the postganglionic fibers, there are difference. Majority of the postganglionic sympathetic fibers, the neurotransmitter is the norepinephrine or noradrenaline. Okay. Majority of the parasympathetic postganglionic fibers, it is the acetylcholine. And apart from this, there are some sympathetic fibers and there are some other areas where there is acetylcholine is also neurotransmitter in case of the sympathetic postganglionic fibers. So, these are the somatic system where the motor neurons are innervated within the somatic system, and these are the autonomic system, the same thing, acetylcholine, preganglionic fibers and then acetylcholine acts. This is the sympathetic preganglionic acetylcholine, then there is epinephrine or norepinephrine. In some cases example is the sweat gland, salivary gland. Here the postganglionic sympathetic fibers, also the neurotransmitter is the acetylcholine, the same thing. Okay. So, it's the same thing. So, you can see how the actions of the somatic, sympathetic and parasympathetic action differs where the dual innervation on this system is present. The red, you can see the red ones are the sympathetic action and the blue ones are the parasympathetic action. So you can see in the eye there are both sympathetic innervation as well as the parasympathetic innervation. Usually what will be the result in some organs? The result will be just the algebraic sum of these two actions of these two systems. In some of the cases when there is flight or fright, there may be some sympathetic system takes over. In some, when there is resting state, parasympathetic system takes over. Ultimately both innervation is present. So when in the sympathetic system in the eye, it mainly causes contraction of the iris radial muscle. So ultimately it causes dilatation of the pupil. While the parasympathetic system in the eye, they causes contraction of the sphincter muscle. So the pupil constricts. This is known as the meiosis. They causes contraction of the ciliary muscles also, that ultimately leads to changes in the accommodation of the eye. So you can see this is an example where the dual innervation is present. Again in the trachea and the bronchioles, sympathetic system ultimately leads to dilatation of this, while the parasympathetic system causes constriction of this and increased secretion of increased tracheal secretion, increased bronchiolar secretion. In the adrenal medulla, secretion of the epinephrine and norepinephrine because there is no parasympathetic innervation. In the kidney also there is only sympathetic innervation, so secretion of the renin happens. In the ureter and the bladder, again dual innervation is present. Sympathetic system causes relaxation of the detrusor muscle, contraction of the trigone, the bladder trigone and the sphincter, while the parasympathetic system causes contraction of the detrusor, relaxation of the trigone and sphincter, just the opposite. So usually the actions of the sympathetic and parasympathetic actions are thus antagonistic to one another. In the genitalia, sympathetic system causes stimulation of ejaculation, while the parasympathetic causes stimulation of the erection in some of the two different mechanisms. Lacrimal gland is mainly innervated by the parasympathetic system, so they causes secretion, lacrimal secretion, stimulation of the tears, all this can happen due to parasympathetic stimulation. In the salivary glands, there occurs thick viscous secretion when the sympathetic system is activated. When the parasympathetic is activated, there will be copious watery secretion. So secretion happens in both of the cases because this is the main actions of these glands, but the property of the secretion is different when the sympathetic system activates and when the parasympathetic system activates. In the heart, there is innervation of both the sympathetic and parasympathetic system. Sympathetic system, when it is activated, that causes increased heart rate, increased contractility of the heart, while parasympathetic system activation causes decreased heart rate, decreased contractility of the heart. Gastrointestinal system, again sympathetic system causes decreased muscle motility and tone, contraction of the sphincters, while parasympathetic causes increased muscle motility and tone, like this. So more or less these are how the difference of the actions of the sympathetic and parasympathetic system. Now coming to the parasympathetic nervous system, already we have seen it is known as the craniosacral outflow. So there are different receptors present in different areas and it acts on the SA and AV node in the heart, it acts on the bronchi and bronchial glands, stomach, small intestine, bile ducts and gallbladder, kidney, large intestine, bladder, genitalia, parotid gland, submaxillary sublingual gland, lacrimal gland and sphincter muscles of the iris and ciliary muscles. So this is more or less where the innervations of the cholinergic system, parasympathetic system is present. Now the main neurotransmitter is the acetylcholine. Acetylcholine for the parasympathetic system in general. There are exceptions, already you have seen. So acetylcholine, how it is synthesized, how it is transmitted. It is mainly the acetic acid ester of choline, acetic acid ester of the choline. Acetylcholine is synthesized in the axonal terminal. So axons in the nerve, terminal of the axons, it is synthesized from the choline and the acetyl coenzyme, okay, by one enzyme. This is known as the cytosolic enzyme choline acetyl transferase. Choline acetyl transferase is the enzyme that causes combination of the choline with the acetyl coenzyme. Of this choline have to be obtained from the outside. Choline is not synthesized de novo, it is to be taken from different types of the foods, it is present in the blood and this choline uptake happens within the body. The acetylcholine is synthesized from the pyruvate in the mitochondria, this acetyl-CoA. So there are two parts, acetyl-CoA and choline. Acetyl-CoA is synthesized within our body from the pyruvate and choline is to be taken from the outside, and choline is transported from the extracellular fluid within the nerves by a high affinity sodium dependent choline transporter. Okay. So basically this is a sodium choline co-transporter, choline, sodium and choline co-transporter that transport choline from the extracellular fluid within the nerve terminal. So this choline transport protein, this is the rate limiting step of the acetylcholine synthesis. So when the choline transporter is inactive or when the choline transporter is blocked, choline will not be taken up by the nerves. So there will be no synthesis of the acetylcholine within our nerve terminals. So that's why this choline uptake and this choline uptake protein, this is the rate limiting step for the acetylcholine synthesis. After entering within this, after formation of the acetylcholine from the choline and acetyl-CoA, it is medically stored at the different types of the vesicles that is present near the action terminals. And then when there is action potential comes, it is released by means of the exocytosis by calcium ion, by the influx of the calcium ion in the synaptic cleft. Okay. So you can see first the synthesis of the acetylcholine happens by the, this is the choline comes from the outside, this is the extracellular fluid by means of the sodium choline co-transporter, that is sodium also enters within the nerve terminals and choline also enters. Acetyl coenzyme A is already synthesized within the mitochondria from the pyruvate. This acetylcholine comes, and from this acetyl-CoA as well as the choline, with the help of the sodium and ATP, acetylcholine is formed. This acetylcholine then comes within the synaptic vesicles, uptake within the synaptic vesicles happen and uptake, and then release of the neurotransmitter happens when there is some action potential comes. This acetylcholine comes within the synaptic cleft. This acetylcholine then binds with the receptor. There are acetylcholine receptor, it binds with the receptor, and again the degradation of the acetylcholine happens when their action is terminated. Degradation is done by the acetyl, there are different types of the enzymes are present, we will come to this later. When the degradation happens, choline is again taken out and acetyl coenzyme is taken out and choline is recycled back. Then choline again comes in the extracellular fluid and then it is again taken up, and ultimately this cycle continues, by which this acetyl coenzyme, acetylcholine is ultimately how it functions. So the same thing you can see, acetyl coenzyme A and choline by means of the choline acetyl transferase is the enzyme that combines the acetyl coenzyme choline with the help of the sodium and ATP to the acetylcholine, and this acetylcholine then comes within the vesicles. Now what happens? Already we have seen this is the rate limiting step, the entry of the choline from the extracellular fluid within the nerve terminals is the rate limiting step for the acetylcholine synthesis, and this rate limiting step can be blocked by one chemical. This is known as the hemicholinium, hemicholinium 3. This is the main chemical formula. Hemicholinium 3 basically blocks the uptake of the choline within the nerve terminals, hemicholinium, and this is another area where the acetylcholine is taken up within the vesicles. This taken up also done by means of another transport protein, vesicle protein, and this is also blocked by another chemical known as the Vesamicol. So Vesamicol is a chemical that blocks the entry of the acetylcholine within the synaptic vesicles that is present near the synaptic cleft, Vesamicol. And then you have seen, then it comes near the axons. When the action potential comes, there will be exocytosis. Exocytosis is usually done when there is rapid influx of the calcium, and then acetylcholine comes in the synaptic cleft. There are some toxins that usually blocks this exocytosis, like botulinum toxin, alpha bungarotoxin. These are the toxins that blocks the exocytosis of the acetylcholine from the synaptic vesicles to the synaptic cleft. This is blocked. And there is another toxin we will discuss, that is the black widow spider toxin. Black widow spider is present, from there a protein is synthesized, that is the black widow spider toxin. that causes rapid secretion of the acetylcholine from the synaptic vesicles. So, there will be depletion of the acetylcholine, just opposite. So, here there will be blockade of the exocytosis by means of the botulinum toxin and alpha toxin, while black widow spider toxin causes rapid release of the acetylcholine from the synaptic vesicles and thus depletion of the acetylcholine. So, ultimately all this leads to less acetylcholine within the synaptic cleft. So, ultimately the actions of the synaptic cleft will be less, so there will be problems. So, ultimately how the different chemicals block at different levels of the acetylcholine synthesis, acetylcholine storage, acetylcholine release and acetylcholine action. Okay. So, remember hemicholinium or hemicholinium 3 is the chemical that blocks the rate limiting step of the acetylcholine synthesis. What is the rate limiting step of the acetylcholine synthesis? That is the uptake of the choline from the extracellular fluid to within the nerve terminals, and this uptake is done by the sodium choline co-transporter. Hemicholinium blocks this sodium choline co-transporter proteins. Vesamicol is another chemical that blocks the vesicle transport protein that transports the already synthesized acetylcholine within the synaptic vesicles. This botulinum toxin, another is the alpha toxin that blocks the exocytosis of the acetylcholine from the synaptic vesicles from the synaptic vesicles to the synaptic cleft when the action potential comes. And another toxin is the black widow spider toxin that causes rapid release of the acetylcholine from the synaptic vesicles, so that there will be depletion of the acetylcholine in the synaptic cleft. It is clear, this 4. So, the same thing, hemicholinium or HC3 blocks choline uptake, the rate limiting step in acetylcholine synthesis, and ultimately all this leads to depletion of the acetylcholine. There will be less or no acetylcholine in the synaptic cleft. Active transport of the acetylcholine into synaptic vesicles is affected by the carrier, which is blocked by the vesamicol. Already we have discussed 2 toxins, botulinum toxin and another is the alpha toxin that inhibits release, and already I have said black widow spider toxin that causes massive release and depletion of the acetylcholine. It is clear? Metabolism or termination of the action. So, after their actions, acetylcholine, then termination of their action is needed. Termination is done by means of the one enzyme. This is not the acetylcholine esterase. This is the main enzyme that causes termination of action of the acetylcholine. Apart from this, there is another enzyme known as the butyrylcholine esterase or pseudocholine esterase. So, acetylcholine esterase, that is, it just blocks, it just breaks down the acetylcholine. Okay. Choline is recycled, already I have said. Cholinergic synapse is very rich of this acetylcholine esterase. Therefore, plasma T-half of the acetylcholine is very short, few seconds. Because if the actions of the acetylcholine is prolonged, there will be problems. So, all this, when the acetylcholine released, there will be small quanta of the release from the synaptic vesicles. When the action potential comes, small quanta released. Within few seconds, its action is terminated. Again, the action potential comes, small quanta release like this. Acetylcholine acts on the different receptors, and then acetylcholine action is terminated by acetylcholine esterase enzyme. All this happens within few seconds. That is why the half-life of the acetylcholine is very short. Even that is why this acetylcholine cannot be used as such as a therapeutic agent, because if we are injecting acetylcholine, its half-life is very short, in few seconds. That will not lead to any therapeutic benefit. That is why. So, why you can be asked why acetylcholine itself is very less used as in therapeutic purpose, because acetylcholine, when it is given in our body, its action is terminated within few seconds. Its half-life is very less. Termination of the acetylcholine is mainly done by the acetylcholine esterase enzyme. Acetylcholine esterase enzyme is present in very large amount near the actions. When the actions of the acetylcholine ends, the choline breaks down from it and choline is recycled back, and acetyl coenzyme ultimately breaks down. So, that is why it is lesser used. 2 types of the acetylcholine esterase is present. One is true acetylcholine esterase, that is the main enzyme that causes breaks down of the acetylcholine. Another is the pseudocholine esterase or butyrylcholine esterase that is mainly present in the plasma. Okay. So, all the pharmacological actions of the anti-acetylcholine esterase drugs are due to inhibition of the true acetylcholine esterase. So, there are some drugs that can also block this acetylcholine esterase enzyme, so that there will be more availability of the acetylcholine. So, they mainly blocks this true acetylcholine esterase enzyme, because the pseudocholine esterase mainly present in plasma, that is very less degrades the acetylcholine. Okay. So, now coming to the cholinergic receptor. So, acetylcholine comes, now acetylcholine have to act on the different types of the receptors, so that there will be actions. So, the receptors, what are the receptors? Receptors can be divided into two. One is the muscarinic receptors and that is the nicotinic receptors. Muscarinic receptors means when it is mainly discovered, it is seen that muscarine is an alkaloid that mainly causes the agonistic actions on this receptor. That is why muscarinic receptor. And nicotinic receptor means nicotine. Nicotine causes agonistic actions on this receptor. That is why it is known as the muscarinic receptor and nicotinic receptor. These nicotinic receptors are basically ligand gated ion channels. So, these are the ion channels are ligand gated, that is when the ligand attaches with these ion channels, ultimately the ion channels ultimately opens or closes. So, ultimately ligand gated, ligand mainly controls whether the opening or the closing of the ion channel happens. So, its activation always causes a rapid, in milliseconds, increase in the cellular permeability of the sodium and calcium, depolarization and excitation. On the other hand, muscarinic receptors are the G-protein coupled receptors. So, there are different types of the receptors you have already read in the pharmacodynamic class. So, there are these ion channels are present, different types of the receptor. G-protein coupled receptor is very common receptor. So, muscarinic receptors, all the muscarinic receptors are the G-protein coupled receptors, all the nicotinic receptors are the ligand gated ion channels. So, there are three muscarinic receptors M1, M2, M3. These three are mainly characterized. Apart from this, there are also M4 and M5 muscarinic receptors, but they are not very significant clinically. So, M1 receptors is also known as the neuronal receptors. So, mainly this is present in different types of the neurons. These are present in the autonomic ganglia, these are present in the CNS. Apart from this, these are present on the gastric glands. M1 receptor, M1 muscarinic receptor. So, these are present in the autonomic ganglia, in the central nervous system as well as in the gastric glands. Ultimately, when these are activated, they causes depolarization. They causes late EPSP, histamine release, acid secretion, learning, memory, motor functions, these are consolidated by means of the actions of the acetylcholine on the M1 receptor. So, M1 receptor already we know that these are the G-protein coupled receptor, they mainly are GQ protein coupled, and when the receptors are activated, there will be some transduction mechanism. Here the transduction mechanism is the IP3DAG activation. So, there are some agonist and antagonist, selective agonist and antagonist of the M1 receptor. Selective antagonist of the M1 receptor is the pyrenzapine. This is clinically important. Pyrenzapine ultimately decreases the gastric secretion because they are M1 antagonist. M2 receptor is mainly present on the heart, and so it is present in the SA node, it is present in the AV node, it is present in the atrium ventricle. In the SA node, when the acetylcholine acts on the M2 receptor, they causes hyperpolarization and decreased rate of the impulse generation. So, ultimately there will be the heart rate will be decreased, there will be decreased velocity of the conduction. So, heart rate is decreased, conduction of the action potential is decreased, shortening of the action potential duration is also decreased. Ultimately, the contractility of the atrium and contractility of the ventricle both are decreased. So, ultimately conduction decrease, that is it causes negative chronotropic, negative bromotropic effect. There are some cholinergic nerve endings where when this M2 receptor is activated, they causes decreased acetylcholine release in some of the cases. In the central nervous system, in some of the cases there are M2 receptor is present that may cause tremor, analgesia. In the visceral smooth muscle, it is present in some of the cases that causes contraction. It is GI-GO protein coupled, The transduction mechanism is mainly by potassium channel opening and CMP. Here the agonist is the methacholine and antagonist is the tryptamine. M3 receptor is mainly known as the glandular receptor. So M1 is the neuronal, M2 is the cardiac, M3 is the glandular receptor, mainly present in the glands, visceral smooth muscles and different types of the exocrine glands. In the visceral smooth muscle, when the M3 receptor is activated, they causes contraction of the visceral smooth muscle. In the iris, there will be constriction of the pupil, that is miosis. In the ciliary muscle, there will be contraction. In the exocrine gland, there will be secretion of the different types of the glands. In the vascular endothelium, M3 receptor is present and they are mainly activated by means of the nitric oxide. That's why these are known as the nitrogen innervation. And when this nitric oxide is activated, they causes vasodilatation. These are GQ protein coupled, IPT-DAG are mainly activated. Beta-nickel is the mainly agonist of the M3 and solifenacin, darifenacin is the antagonist of the M3. So these are the M1, M2, M3. M1 is the neuronal, mainly present in the CNS. M2 is the cardiac, mainly present in the heart. M3 is the glandular, mainly present in the smooth muscle and exocrine glands. Okay. Apart from this, there are some M4. This is present in some areas of the CNS that causes enhanced locomotion, analgesia and facilitation of the dopamine release. And M5 is also present in some areas of the CNS that facilitates dopamine release, augmentation of the drug seeking behavior and reward mechanism, These are less characterized, M4 and M5. So after the muscarinic receptors, next receptor is the nicotinic receptors. There are two types of the nicotinic receptors, NN and NM. NM means the neuromuscular receptor that is present in the neuromuscular junction. Nerve and muscle, neuromuscular junction contains the NM receptor. So they mainly causes depolarization of the muscle end plate and contraction of the skeletal muscle when these NM receptors are activated. Whereas the NN receptors are present on the autonomic ganglia mainly and they causes depolarization and the postganglionic impulse are generated. This is also present in the adrenal medulla. When this adrenal medulla NN receptors are activated, there will be release of the catecholamines. In the CNS, they causes site specific excitation or the inhibition. So the agonist of the NM receptor and NN receptor both is the nicotine, whereas the antagonist is the alpha bungarotoxin and tubocurarine. These are the NM receptor antagonists. We'll read more about this in the muscle relaxation class. Whereas the NN receptor antagonists are the different types of the ganglionic blockers like hexamethonium trimetaphan. Okay. So NM receptor, NN receptor. NM means neuromuscular junction, NN means neuronal, mainly the autonomic ganglia and adrenal medulla. So we can see the summary of the adrenergic and cholinergic responses. So in the heart, already you have seen in the sympathetic system mainly accelerates the heart. Where the parasympathetic system mainly decelerates the heart. So acceleration of the hearts mainly happens in the sympathetic system by beta 1 receptor. So in the sympathetic system already we have read about the different receptors. Main receptor is the beta 1 receptors in the heart, whereas in the parasympathetic system the main receptor is the M2 receptor that is present in the heart. Similarly, in the vascular smooth muscles, alpha receptor is the main that causes contraction, but in the parasympathetic there is no such. In the bronchiolar smooth muscles, beta 2 receptor relaxes, whereas M receptor, mainly M3 receptor, mainly contracts like this. Gastrointestinal and smooth muscles, there are alpha 2 and beta 2 receptor relaxes, whereas the M receptor contracts. Genitourinary smooth muscle, beta 2 receptor relaxes, M receptor contracts. That is more or less antagonistic actions of the sympathetic and parasympathetic system. Similar in the skin mainly the sympathetic innervation is present. So ultimately it causes contracts. Sweat gland, there will be increased secretion of the sweat gland. But the neurotransmitter here is the acetylcholine. That's why the receptor you can see muscarinic. So this is the exception. Here the postganglionic sympathetic fibers, but the neurotransmitter is not the norepinephrine. Here the neurotransmitter is the acetylcholine. So you can see there is no parasympathetic innervation in the sweat gland. But here the receptor on which it acts to increase the secretion of the sweat gland is the muscarinic receptor. So, because here the neurotransmitter is the acetylcholine. So, like this. So, now communication of the cholinergic drugs. This cholinergic drugs is also known as the parasympathomimetic drugs. So, basically they acts like that of the parasympathetic system. That is why it is known as the parasympathomimetic drugs, cholinergic drugs. So, there are some directly acting cholinergic drugs like acetylcholine, which is the prototype, but it is not used therapeutically as such. There are some synthetic choline esters like methacholine, carbachol, betanicol. Of this, betanicol is mainly used therapeutically. Methacholine is used in some diagnostic cases. We will discuss about this. There are some natural alkaloids that are also acts as a parasympathomimetic agents like aricoline, nicotine, muscarine, pilocarpine. Of this, pilocarpine is used therapeutically. Pilocarpine is mainly used in glaucoma. Okay. And there are some indirectly acting parasympathomimetic agents. Indirectly acting means they are mainly blocking the degradation of the acetylcholine. That is, they are mainly blocking the acetylcholine esterase enzyme. So, they are anti-acetylcholine esterases. So, anti-acetylcholine esterases are the indirectly acting parasympathomimetic drugs. These are directly acting, these are like that of the parasympathetic system, and they are blocking the degradation of the acetylcholine. So, that can be divided into reversible and irreversible. So, reversible blockage of the acetylcholine esterase enzyme and irreversible blockage of the acetylcholine esterase enzyme. Reversible blockage may be done by the natural alkaloids like physostigmine. There are some quaternary compounds like hydrophonium, neostigmine, pyrrostigmine, rivastigmine, etc. Mostly these are used in different types of the diseases. We will discuss about this later. And there are some irreversible anticholinesterase agent, mainly this causes different types of the poisoning. These are used in different insecticides, okay, like ecothiopate, isoflurane, paraxon, parathion, malathion, carbamates like propoxur, different types of the nerve glasses are there. So, usually the irreversible anticholinesterase enzymes are mainly used in different types of the poisoning, and we have to know about how to treat this poisoning. So, like this organophosphorus poisoning, we will discuss, very important. And this reversible anticholinesterase enzymes, these are mainly used as drugs in different types of the disease. For example, this is used in myasthenia gravis, this is used in Alzheimer's disease, like this. Now, the question is, what are the pharmacological actions of the acetylcholine in the human heart? Human heart ki action ache. So, the primary cardiovascular effects of the muscarinic agonist are a reduction in the peripheral vascular resistance and changes in heart rate. So, acetylcholine mainly acts in the cardiovascular system. One is M2 receptor is present within the heart, and M3 receptor is present within the blood vessels, endothelium of the blood vessels. But in the endothelium of the blood vessels, there is no direct innervation of the cholinergic nerves, but when these cholinergic nerves are activated, there will be release of the nitric oxide. So, these are known as the nitrogen nerves, and ultimately they causes vasodilatation. So, when there is vasodilatation, the peripheral vascular resistance will be decreased, and when the M2 receptor within the heart is activated, all the actions of the heart are decreased. So, there will be decreased SA node impulse, there will be decreased contraction, decreased impulse generation, all these are decreased. So, when intravenous infusion of the minimally effective dose of the acetylcholine in humans is given, approximately 20 to 50 microgram per minute, that causes vasodilatation, resulting in a reduction in blood pressure, often accompanied by the reflex increased heart rate or tachycardia. So, when this is given instantaneously, because the M2 receptor within the heart usually takes time for its blockage, but the usually release of the nitric oxide causes the vasodilatation. When there is vasodilatation, there will be reduction of the blood pressure, and to counteract this, there will be increase of the heart rate. This is known as the tachycardia, this is known as the reflex tachycardia. So, when a minimally effective dose of the acetylcholine is injected intravenously in our body, there will be first decrease of the peripheral vascular resistance, there will be decrease of the blood pressure, that in turn leads to increased heart rate. This is known as the reflex tachycardia. When larger doses of the acetylcholine is given and for a long period of the time, that ultimately blocks the M2 receptor also, and ultimately that causes then bradycardia. That causes bradycardia and decreased atrioventricular node conduction velocity in addition to the hypotension. Hypotension is already there, blood pressure is already less. So you may be asked that when the acetylcholine is given, what will be the effect, or why there is first tachycardia and then bradycardia? So it is clear, when the acetylcholine is given in our body, first it acts instantaneously on the blood vessels, because the blood vessels, there will be release of the nitric oxide, there will be vasodilatation of the blood vessel. When there will be vasodilatation, the blood pressure will fall. When the blood pressure will fall, there will be reflex increase of the heart rate, because the heart have to propel the blood in the different organs. The blood pressure already is decreased. That is why there will be reflex tachycardia. But when the acetylcholine is given for a long period of time or with a very high dose, that also blocks the M2 receptors in the heart. And already we have seen that the M2 receptor is present in the SA node, it is present in the AV node, it is present in the atria, it is present in the ventricle. In all of the cases, it decreases the contraction, it decreases the impulse. So ultimately all this leads to bradycardia. So it is clear. So the direct cardiac actions of the muscarinic stimulants, the same more details, and increase in the potassium current in arterial muscle cells and in the cells of the sinoatrial and atrioventricular nodes, SA node and AV node, a decrease in the slow inward calcium current. So these are the inherent molecular mechanism by which, when it attaches with the M2 receptor, how the heart rate decreases. So there will be an increase in the potassium current, there will be decrease in the inward calcium current, reduction in the hyperpolarization activated current. So ultimately causes the slowing. All these are mediated by the M2 receptor, slowing the pacemaker rate. So pacemaker, what is the main pacemaker of the heart? Is the SA node. SA node is the pacemaker of our heart. So this is decreased. Okay. So all this causes to hyperpolarization and decrease the contractility of the arterial cells. There are different actions on other systems also, already we have seen. So in the gastrointestinal tract, acetylcholine means increased secretion. Okay. So all muscarinic agonists causes increased tone and motility. Large doses will cause spasm and tenesmus. Spasm, gastrointestinal spasm can happen. In the urinary tract, the choline esters and pilocarpine contract the detrusor muscles of the bladder, increase the voiding pressure, decrease bladder capacity and increase ureteral peristalsis. In addition to this, the bladder trigon and external sphincter muscle relax. So ultimately they causes contraction of the detrusor muscles of the bladder. So cholinomimetic drugs, all this causes contraction of the detrusor muscles of the bladder. Okay. In the exocrine glands, the choline esters and muscarinic alkaloids, they stimulate the secretion of the different types of the glands, lacrimal gland, salivary gland, different digestive gland, tracheobronchial trees, sweat glands, etc. So all these glands causes increased secretion. Of this, again remember, the sweat gland, salivary gland mainly innervated by the sympathetic nerves, but here the neurotransmitter is the acetylcholine. Okay. Salivation also is increased markedly by the pilocarpine. Respiratory system, in the respiratory system there will be increased secretion in the tracheobronchial trees. The bronchial smooth muscle is stimulated. Cardiovascular system already we have discussed. Now if pilocarpine is injected through IV route, what will happen? Details of the pilocarpine we will see. So pilocarpine is a prototypical parasympathomimetic drugs. So it behaves like that of the acetylcholine. So the cardiovascular effects of most of the cholinomimetic natural alkaloids and synthetic analogues are similar to those of the acetylcholine. So pilocarpine is an exception, somewhat it is exception. Why? If it is given intravenously, it may produce hypertension after a brief initial hypotensive response, because it happens due to sympathetic ganglionic discharge by the activation of the postganglionic cell membrane M1 receptors. So pilocarpine also activates the postganglionic M1 receptors. Okay, that's why if pilocarpine is given intravenously, that may cause hypertension instead of the hypotension. But remember, pilocarpine is not given by intravenous route. Pilocarpine only uses as eye drop in the eye as in the glaucoma. But remember, the exception of the pilocarpine action in comparison to the other cholinergic agent because they also activates the postganglionic M1 receptors that causes sympathetic ganglionic discharge. Most sympathetic ganglionic discharge happens. So, sympathetic discharge means there will be more noradrenaline. More noradrenaline means that causes increase of the blood pressure. So, ultimately they causes hypertension. So, this may happen with the pilocarpine. What are the pharmacological effects of the cholinergic drugs on the GIT? Already we have discussed. In the gastrointestinal tracts, all the cholinergic drug causes increased secretion, increased motility, increased tone of the gastrointestinal muscles and increased tenesmus. All this can happen. So, all this happens due to depolarization of the smooth muscle cell membrane and increased calcium influx. So, mainly this happens by means of the M3 receptor and M2 receptor. M3 receptor is required for direct activation of the smooth muscle contraction, while M2 receptor reduces the CMP formation and relaxation caused by the sympathomimetic drugs. So, the same thing I am just repeating so that it will be easy for you. So, in the gastrointestinal system it causes increased secretion. Therapeutic uses of the acetylcholine. Acetylcholine is available as an ophthalmic surgical aid in limited of the cases for the rapid production of the meiosis. Meiosis means decrease, that is smaller of the people. Pilocarpine is available as a 5 or 7.5 milligram oral doses for the treatment of the xerostomia or as ophthalmic solution. Xerostomia means when there is dry secretion from the salivary glands. So, this may happen. So, we have to increase the salivary secretion. So, we can use the pilocarpine apart from using the glaucoma. Methacholine may be administered for diagnosis of the bronchial hyperreactivity. Methacholine is an cholinergic ester that is not used therapeutically, but it is used diagnostically to see whether there is any bronchial responsiveness, whether there is hyperresponsive or hyporesponsive or not. Cevimeline is a newer muscarinic agonist with activity at the M3 receptor. They are also used in the xerostomia. Agonists for the M1 and M2 receptors have been targets for the drug development, mainly for the cognitive impairment associated with the Alzheimer's disease. So, it has been seen that this M1 receptor and different other muscarinic receptors are also present in different areas of the brain that mainly causes the consolidation of the memory. So, ultimately different trials are also ongoing to see whether this muscarinic agonist, that is the cholinergic different drugs, can be utilized in the Alzheimer's disease, memory consolidation, etc. or not. Why acetylcholine is not used clinically? Already I have discussed. Acetylcholine is rapidly metabolized by the acetylcholine esterase enzyme. Its actions are of very short duration, poor penetration through cornea. So, when it is given in the eye drop, also its penetration in the cornea is very poor, rapidly broken down by the acetylcholine esterase before it reaches its site of action. That is why acetylcholine is not used. Pilocarpine is the main cholinergic drug that is very commonly used. Pilocarpine is mainly obtained from the leaves of the Pilocarpus microphyllus. Pilocarpus microphyllus is a plant. From the leaves the pilocarpine is obtained. It has prominent muscarinic actions and also stimulates ganglia, mainly to ganglionic muscarinic receptors. So, within the ganglia also there are muscarinic receptors. Already we have seen there are some M3 receptors are present. So, they mainly have muscarinic actions. Pilocarpine mainly has muscarinic actions. There are very less or no nicotinic actions. They causes marked sweating, marked salivation and increases other secretions. So, sweating, salivation, all these are increased. That is why it can also be used in xerostomia. The cardiovascular effects are complex, already we have seen, because they are also activates the autonomic muscarinic receptors. That is why there may be some hypertension when the pilocarpine is given due to ganglionic stimulation. When it is applied to the eye as an eye drop, pilocarpine eye drop, it penetrates cornea and promptly causes the meiosis, ciliary muscle contraction and fall in intraocular tension lasting 4 to 8 hours. So, in the glaucoma there will be increased intraocular tension. So, when this pilocarpine is given, pilocarpine causes fall of the intraocular pressure. So, ultimately the glaucoma can be relieved. It is used only in the eye as 0.5 to 4% drops. It is mainly the third line agent in open angle glaucoma because newer, more advanced drugs are already there for the management of the glaucoma. And there are some adverse effects like some initial stinging sensation in the eye may happen when you are instilling pilocarpine drops. Painful spasm of the accommodation are also frequent side effects. Accommodation of the eye, that is also paralyzed. There will be ciliary muscle contraction that leads to paralysis of the accommodation. Other uses as a meiotic are to counteract the mydriatics after they have been used for testing refraction. So, when the refraction is tested, when you are given the spectacles at the first, you will be given one eye drop, that is a mydriatic eye drop. Mydriatic eye drop is mainly the anticholinergic eye drop. You read in the anticholinergic class, that is just opposite, anticholinergic eye drop. But when the anticholinergic eye drop is given, refraction is given, then to terminate the actions of the mydriatic, meiotic eye drop like this pilocarpine can be given. Next is to prevent or break adhesions of iris with lens or cornea by alternating it with mydriatics. This may happen, adhesions of the iris with the lens or cornea in different types of the eye infections. Here we have to give the alternative meiotic and mydriatic. So, meiotic is always the parasympathomimetic agent like pilocarpine, and mydriatic is just opposite, anticholinergic agents. Though it can also be used as a sialogogue, no oral preparation is available. Sialogogue means increased salivary secretion, usually there is no oral preparation. Betanicol is next drug that can be used, but it is also lesser used nowadays. Betanicol is used in certain cases of the post-operative abdominal distension and in gastric atony or gastroparesis. So, the gastric motility is very less. This usually happens after some operation, after some surgical intervention. There may be some surgical atony, gastric atony. It can afford symptomatic relief in congenital megacolon. In congenital megacolon, the gastric motility is lost. Here it can be used. Gastroesophageal reflex, but it is rarely used nowadays. Most commonly it is now used in treating urinary retention and inadequate emptying of the bladder, because already we have seen what are the actions of the acetylcholine or cholinomimetic agent. They causes contraction of the trigon, bladder trigon. They causes relaxation of the sphincter muscle, so that there will be more release of the urine. So, when there is urinary retention, that is urine cannot be passed out. So, urinary retention. So, the urine is stored, but urine cannot be passed out due to atony of the bladder muscles. So, here we have to use the cholinomimetic agents like betanicol. Postpartum urinary retention, this usually happens after some operation. So, after some operations it may happen. Postpartum urinary retention is very common, that is after delivery of the baby, usually in the cesarean section there may be some postpartum urinary retention, urine is not happening. Here we have to give the cholinomimetic agent, most commonly the betanicol. In certain cases of the chronic hypotonic, myogenic or neurogenic bladder, this hypotonic, myogenic or neurogenic bladder means there are different types of the problems, that may be some myogenic problem or neurogenic problem where the bladder muscles are not working. When the bladder muscles are not working, you read in the anatomy and physiology how the micturition happens. So, if the bladder muscles are not working, there will be urinary retention. So, here we can use the betanicol. Side effects may be belching, some colic, involuntary urination and defecation, flushing, sweating, fall in blood pressure, bronchospasm. So, there are some numerous types of the adverse effects are there. That is why it is less used nowadays in case of the urinary retention. Botulinum toxin. Botulinum toxin, this is obtained from the Clostridium botulinum type A and B, and they mainly causes the botulism. Botulism is a type of the food poisoning. Okay, Clostridium, that if the food is stored for a large number of days in hot humid conditions, there may be some Clostridium botulinum infestation and botulism, food poisoning can happen. But here the botulinum toxin can be extracted, and this botulinum toxin can also be used therapeutically. So, these neurotoxic proteins mainly cause long lasting loss of the cholinergic transmission by interacting with axonal proteins involved in exocytotic release of the acetylcholine. Remember, the botulinum toxin and alpha bungarotoxin, they causes blockade of the exocytosis of the acetylcholine from the synaptic vesicles within the synaptic cleft. Already remember, exocytosis, they causes the blockade. So, this botulinum toxin, when we are giving some localized injection of the botulinum toxin, is minute quantities, mainly the botulinum toxin A, also known as the Botox, or its hemagglutinin complex, that will be a longer lasting, known as the Dysport. They are used in different types of the spastic and neurological conditions. Different spastic conditions, neurological conditions, it can be used, and overactivity of the cholinergic nerves, and also in some cosmetic purpose like to remove the wrinkles. Okay, Botox injection is given. Here the botulinum toxin is given. They mainly blocks the exocytosis of the acetylcholine from the synaptic vesicles that is present near the axonal terminals within the synaptic cleft. Remember? They are also used in blepharospasm, spastic cerebral palsy, strabismus, spasmodic torticollis, nystagmus, hemifacial spasm, post-spasticity, spasmodic dyspnea, axillary hyperhidrosis, etc. All this happens due to more acetylcholine in the synaptic cleft, this spasticity. So, this spasticity can be treated by means of the botulinum toxin. So, basically it is a toxin, but ultimately we use in the therapeutic purpose also. It is increasingly being employed as a beauty treatment. You know about the Botox treatment. The celebrities are usually taking the Botox treatment by removal of the age related facial wrinkles. Botox injection is given, but there are numerous side effects also. However, its incorrect injection or overdose can be dangerous, because ultimately we are blocking the acetylcholine. So, there may be ptosis, the drooping of the eyelid, diplopia, that is dual, the eye, we are seeing 2 or 3 people at a time, facial swelling, there may be dry mouth, that is just opposite of the actions of the acetylcholine. There may be dry mouth, there may be dysphagia, there may be dysarthria, muscular weakness, and even respiratory paralysis. So, even there is some increased dose, or even there is some areas where it should not be given, there may be problem of the botulinum injection. So, this is more or less about the today. From the next class, we will discuss about the rest portions of the cholinergic system. So, within this cholinergic system, this is very important, very complex. You have to read all these parts of the ANS or the general pharmacology today itself, otherwise it will not be grasped by you. Okay. So, you have to read about the cholinergic system. You have to start what is the different types of the neurotransmitter, where the acetylcholine is the neurotransmitter, where the noradrenaline is the neurotransmitter. Now, how the acetylcholine is synthesized, what are the rate limiting steps, what are the different chemicals or drugs that blocks at different areas, how it is stored, how it is secreted, and where it acts, different types of the receptors, what is the location of the M1 receptor, M2 receptor, MT receptor, NM receptor, NN receptor, and what are the different actions of the cholinomimetic agents or the acetylcholine, actions on the heart, actions on the GI system, actions on the urinary, bladder, etc. Different types of the drugs like Pilocarpine, Bithanicol, what are their actions, etc. Okay. Any questions? Okay. Thank you.